All right, well, why don't we go ahead and get started and I'll just keep letting people in if they come. So I'm
Okay.
gonna hand it off to Kagan. Go ahead.
Okay. Hello, everybody, and welcome to our Transition Table Talk event, where we will be discussing healthcare transitions and all things that come with it. Oh, can you guys hear? Yep, okay.
I can't hear Chaley.
Okay, yeah, that's what I mean.
Sorry, no, can't hear Shaylee. Shaylee, can you try to call in? You want to just go ahead, Kagan? And
Mhm. I'll still introduce Chaley. So her name is Chaley McClee. She lives with psoriatic arthritis, and she's a member of YP Areas. Yeah, YP Area. YP Area is um, a council made up of young patients with autoimmune conditions who are passionate about research. We seek to make healthcare research accessible and inclusive by empowering young patients with relevant information about autoimmune diseases and the skills to engage in all stages of research. My name is Kagan Ellis, and I'm an ulcerative colitis patient with an ileostomy, and I'm also a member of YP Area. Though I began talks of transitioning at 17, the age I was diagnosed at, an unstable medical journey made the process a complicated one. Now at age 20, I just now am finally at a place where I have both my pediatric team and upcoming appointments and plans with the new adult GI. We are so excited to be hosting this table talk event with one of our close community partners, Infusion Access Foundation. They're a community of patients and advocates who aim to empower individuals and help them advocate for access to their treatments so that everyone can live their best and healthiest lives. Today we have two amazing experts, Dr. Erica Lawson and Dr. Jordan Shapiro. Dr. Erica Lawson is a pediatric rheumatologist and medical educator at the University of California, San Francisco, where she joined the faculty in 2013. She provides care to children, teens, and young adults with chronic rheumatic diseases. Her research and quality improvement work focus on transition from pediatric to adult care for individuals with childhood onset rheumatic diseases and a focus on health disparities. She serves as the program director for the UCSF Pediatric Rheumatology Fellowship and the Pediatric Clerkship Director for the UCSF School of Medicine. And Dr. Jordan is a board certified adult gastroenterologist and the founder of Gentle GI. In addition to caring for patients with common GI concerns, he has specific expertise in disorders of gut-brain interaction, such as irritable bowel syndrome, or IBS, inflammatory bowel diseases, such as Crohn's disease and ulcerative colitis, pelvic floor disorders, GI complications of eating disorders, and transition from pediatric to adult GI care. He embraces evidence-based medicine, multidisciplinary care, and trauma-informed care. He loves to think outside of the box. He welcomes and celebrates patients from diverse backgrounds and experiences, including those who identify as LGBTQ+ and those with histories of trauma. So without further ado, let's get started. First, we will begin with Dr. Erica Lawson and Dr. Jordan Shapiro, who will share 15 minutes of what they consider to be the most important things to know about transitioning care. Then we will open the floor to questions from you and other members of YP Area. We will ask that all participants please stay muted during the event, but flood the chat with all of your questions and comments. We have a few of our wonderful YP Area members monitoring the chat to make sure everyone is heard. We would also like to remind everyone that this event is recorded and will be made public. So first up, we have Dr. Erica Lawson. Your time begins now.
All right. Hi, guys. It's so great to have everyone here. And yeah, really, really nice to see you all. It's really one of the great pleasures of my job to be able to work with young people with rheumatic diseases and watch them grow up and go from, watching their parents really running the show completely to watching them become independent and capable young people. So I'm really feel very honored to be here with you all today. I first got interested in the idea of transition when I was a pediatric rheumatology fellow. So I did my training in pediatrics at Seattle Children's Hospital. I came down to San Francisco to do a pediatric rheumatology fellowship. And I just started noticing how it seemed like some patients were sort of able to like make their way through the system and things went okay. And other people really, really struggled, and started thinking a little bit about what that meant. And some of that, now looking back, are things that I think, this was back in like 2009, that we didn't have great language or as common language for at the time, things like social determinants of health, that really affected how a lot of my patients experienced the medical system and how they were able, to manage their own conditions. But I wanted to understand that better, and I wanted to understand how we could support those patients that were struggling so they could be successful and live their best, their healthiest possible lives with chronic illness. So another important concept that's good to introduce upfront is transition versus transfer. And I apologize if some of you are familiar with this already, but maybe some of you aren't. So transition, I think of as being a much more global concept. This is really how you get from being a little kid who maybe kind of sort of understands what's going on, but not really, with the parents completely in charge, to being a capable, competent young adult who can manage their own care. And then you have this concept of transfer, which is really moving from a pediatric-oriented medical care system to an adult-oriented medical care system. And that happens most often by moving from a pediatric provider to an adult provider, but not always. So some people might go to rheumatologists who are trained, or other subspecialists who are trained in both pediatric and adult medicine, and they can stay with the same provider. But there's still this transition of the dynamics of the care, and we'll talk a little bit more about what that means. So one of my other important takeaways over the years with regard to transition is this is not a one-size-fits-all situation. And I sort of alluded to that earlier, right? And some of the factors that really affect what people need to be successful during transition include their own self-efficacy. There are some young people who are just ready to dive in and take charge. They'll manage their own medications, they'll make phone calls, they'll schedule appointments, and other people where they feel a little intimidated, or maybe they have parents who really like to be in charge of that stuff and it's hard for them to let go. So there's a social dynamic factor as well. So sort of there's a concept we talk about called self-efficacy, which is this idea of being able to kind of take care of stuff for yourself and having confidence in your ability to do that. And then there's also a family and social dynamic factor. And then there's illness factors. So, people who have relatively well-controlled disease, it's easier to manage. It's less complicated, right? If you're really, really sick and have a lot of complexity going on, transition becomes much more difficult because it's just harder to keep all these ducks in a row and things are changing constantly. There's also insurance factors. So where you practice makes a huge difference in terms of what transition needs to look like and what state you are living in and what type of insurance you have. And then there are factors around access to adult care. So there are some communities where finding an adult specialist can be really hard. And so you actually, in order to transfer, need to find the doctor that you can go to. So these are some of the things that we think about. I'm going to take a step back and talk a little bit about how we approach transfer at UCSF. Some of this stuff is translatable, and I'll try to point out some of the areas where it really is specific to our practice environment in California. So in terms of when is the right time to transfer, I saw some questions that were submitted ahead of time about this. And some of the important factors I think about are being, first and foremost, medically stable. So whenever possible, you do not want to switch doctors when you're in the middle of a medical crisis. The risk of things getting miscommunicated, slipping through the cracks, your quality of care suffering really goes up. So whenever possible, we always want to transfer when things are relatively stable. And then there's insurance. So in California, we have a public health insurance system called California Children's Services that a lot of our patients have. And those patients have to transfer on their 21st birthday. Sometimes we can beg and plead and extend things a little bit, but it's basically complicated for them to transfer earlier and complicated for them to transfer later. Based on what I just said, depending on what's going on with them medically, that can create some challenging situations. So this is something that varies state to state, but if you have Medi-Cal, say in I know a lot of the southern states, Medicaid, we call it Medi-Cal in California, Medicaid in some of the southern states, that expires right on your 18th birthday. So you gotta get transferred sooner. So that's something to know about where you live. If you have private insurance, there's more flexibility. So legally, people who are on their parents' private insurance can stay there until they turn 26. So lots more breathing room, which is nice. And then another factor that comes in is like where you're actually physically living. So for folks who are going out of state for college, there are conversations that we need to have. And this is where, for me, telehealth has been very helpful because I will sometimes have patients very frequently who are going away for college. We do video visits and then they see me in person when they come back. But that's another piece to navigate. Our practice provides a transition guide that tells our patients some of the information I just talked about. So how to think about when is the right time for you to transfer, and then also what you can expect from us. So in terms of what kind of support you're going to get and what you're going to need to manage on your own. Because there is a lot of, there's definitely some legwork required from patients and families, obviously, to make this happen. So we try to think about, in our practice, how to identify the patients that really need support and are likely to have a more challenging time with transition. And some of the things that the factors that we try to identify that might kind of indicate, oh, this is someone who might need a little extra help. Are patients who have infusion medications, so they have to get their infusion set up and you don't want to have a gap in infusions. That's something we always worry about when you're making that transition. So really good to think about that ahead of time and make sure that those things are scheduled. Patients who have complex illness or multiple subspecialists, there's just more that they need to manage and might benefit from some help. Sometimes we can anticipate certain insurance transitions or insurance gaps. I talked about, in California, making this switch off of California Children's Services is something that we really try to anticipate so that we don't get gaps in care. And then there are other roadblocks to care that we take into account. So things as simple as language barriers. We have, out in California, in the Bay Area, many of my patients are non-English speaking, Spanish, Chinese, everything under the sun. And so those patients have a harder time navigating systems and also often benefit from some help. And then patients who have had already a hard time getting to appointments with frequent no-shows, there's actually research that demonstrates those are some of the patients who are most likely to kind of fall off the cliff when they're going to adult care. So those are good patients to engage early too. One thing that's really important as you're starting to think about this transfer process is to make sure that you have an adult primary care provider. That's often a really good first step. One of the differences in structure between the pediatric system and the adult system is that on the adult side, your primary care provider really is the center of your medical universe. And for a lot of pediatric patients, that's not really the case. Like you see your pediatrician maybe once a year, you get shots that you need, but for the most part, your specialists are totally driving the boat in terms of the great majority of your care. Adult care is much more centered around primary care providers, and depending on the insurance you have, you may actually need a referral from your primary care provider to access an adult specialist. And so getting into a primary care provider who sees adults early is really good. And depending on who you're seeing, if you're seeing a pediatrician, you need to transfer, but if you're seeing a family doctor or a doctor who's trained in medicine and pediatrics, so adult and pediatric medicine, you may not need to transfer, but that's a good thing to look into and think about early on. All right. So what are the things that you can do to, well, let's talk a little bit about some of the differences between pediatric and adult care, what to expect. Let's see. I know I'm tempted to do Q&A, but I know they told you guys to keep your audio off, so I'll follow the rules unless I'm told otherwise. But what do you guys think? Is it okay to do some Q&A?
People can put it in the chat for sure.
Oh, great. That's perfect. Okay. So, some of you may have already been to adult care. Some of you are just thinking about it, but I would love to hear from you all. What are some of the things you have experienced to be different or think might be different? So differences between pediatric care and adult care. What do you think? What might be different? Our chat is very quiet. There we go. All right. Yeah, so Christine mentioned length of appointments. So appointments on the adult side are typically shorter. Terminology used between patients. I'm curious what you mean by that. So feel free to clarify in the chat. Yeah, Ella also mentioned length of appointments, differences in time spent. Jen mentioned, yeah, the look and feel of the clinic is different, right? So pediatric clinics often have bright colors and toys and lots of young people. I've been told by some of my patients the first time they go to an adult provider, there's like a lot of old people in the waiting room. And that feels a little weird, right? You're like, what am I doing here? Time spent with caregivers or parents in the room, right? So hopefully, I certainly encourage all my adult providers that I work with to, allow parents to be a part of the discussion if they want to. We don't want them to feel like anxious or kicked out of the conversation, but you definitely have to spend time solo with your provider. Hopefully you're doing that already with your pediatric provider, but if not, you for sure need to start doing it with your adult provider. Kagan mentioned expectations of ability to manage your care and effectively answer questions. Yeah, they kind of expect you to be a grown-up, like to take care of stuff. And I know that can feel like a big switch. Yeah, interesting. And then this is interesting. Kindle says, felt like pediatric care was a straightforward curriculum, and then adult care felt optional and easy to ignore or forget about. That makes sense to me, actually. So one thing on the pediatric side is we're actually much more paternalistic. Like we're more like parents. We're like, you got to do this and you got to do this. And, if not, we're going to call you. And on the adult side, it's much more, you're an adult, you make your own choices. I will give you my recommendations for how I think the things I think you should do, but there's much more acceptance when people are like, nah, I don't want to do that. Which feels really different too, right? And then it becomes really much more up to you to take the initiative because you don't have someone breathing down your neck about it. Access to wraparound services like mental health, dietitian, social work, etc. That is also very true. So on the adult side, we are very fortunate in pediatrics to have a lot of ancillary services available in many cases. And it's usually a little more pared down in adult care. Meds available. So you may have access to more medications, right? After you turn 18, there's some medications that are just approved in adults, and it might be easier to get your insurance to approve those. So that's a positive thing. Yeah, Maggie mentions adult care definitely feels more independent. I remember not knowing that if I needed something specific, I needed to advocate for myself, but sometimes I didn't know how to. Oh, yeah. So let's talk more. We can talk more about that later. Yeah, more conversational and less directional. But you have a rockstar PCP. I'm so glad. Yeah, a rockstar PCP is really important, and Maggie, you can probably appreciate how, having that PCP that you really trust actually becomes like a very critical part of getting the care that you need. Great. All right. So a couple other things just as we're wrapping up, that I think folks can do now. Christine mentioned one more thing. Understanding that pediatric onset conditions may be different than ones diagnosed in adulthood. Sometimes I feel like we have to explain that there are nuances. That is not surprising. Yeah, because they're not used to taking care of as many, the great majority of adult providers' patients are folks with adult onset disease. Okay. So just to finish up, a few things that you can think about doing as you are getting ready to make this transfer. I think it's great to start, if your parents are still really involved in your care, just start asking some questions. And I know it's not, always like the thing you want to do on like a Thursday is learn more about how your parents manage your medical care. But the more of this stuff you can do before you like head off to college or are in places where it's more difficult to get that parent support, the better and the more comfortable you're going to feel. Some folks want to start learning how to do their own injections, especially if they think they might be like moving away for college or, again, like living independently so that other people won't be able to do that stuff for them. Getting more, making sure that you're independent with managing your medications and figuring out like what works for you. What's a good routine in terms of, pill box, alarms, like how are you going to make sure that you're on top of your meds if your parents aren't reminding you. So just a few suggestions for some things to think about doing now as you are getting ready for the next step. But like, you know, like I started, I do, even though it can feel intimidating, I think making this transition, I think for a lot of patients, it also feels really good. Like you are stepping into your own, taking charge of your own destiny, making your own decisions. And that's scary, but it's also awesome. And know that, you know, I think for most of us speaking as like a pediatric provider, if my patients reach back out to me to get advice or say hi, I am always delighted to hear from them. So know that even if you are moving on from your pediatric providers, I'm pretty positive they're all happy to hear from you if you ever want to reach out to them.
Dr. Lawson, that was so great. Just hearing you touch on like some of the roadblocks to care, that's just really important to acknowledge in terms of like having equity in the healthcare field. And then what you said about having an adult primary care provider, honestly, I would have loved to have heard the emphasis on that before I started transitioning because I definitely have a gap in that area. But just thank you for your attendance, and that was just amazing, and I'm so glad to hear from you. So next we will hear from Dr. Jordan Shapiro, and your time begins now.
Fantastic. That was very educational to me, and I learned a lot from that too. Really happy to be here. And I'm sure in the communications after my section, we'll learn more from the patients too. You know, I did train in pediatrics and internal medicine. I was a special needs pediatrician for about a year and a half at Texas Children's, and then I had always planned back to go back and do GI. And I didn't know if I was going to do kids or adults. And I found there was a huge vacuum of adult or lack of adult providers that really love adolescents and young adults. And I think like it was interesting to me because so much of pediatric care is about, there's this term anticipatory guidance. Like it's so much of pediatrics from the moment a child is born, letting the parents know like, hey, you know, at 2 months, they should be doing this. At 4 months, they should be doing this. So we do this all the way up until adolescence. And then everyone gets a little uncomfortable with like, what does anticipatory guidance look like? Including the fact that eventually, regardless of what system policies are, that whether it's 18 or it's, you know, for patients often with commercial insurance, they're given additional time or given a little bit more time to linger in pediatric care, whereas you know, someone with Medicaid may have to go right away. But like everyone is a little uncomfortable. And then the adult side, there've been studies showing this, but I think if you ask most internal medicine doctors or adult subspecialists, their comfort level with adolescents and young adults, it's not great. And so there's like everyone is just a little unsure of like, what do we do? Even though everything leading up to that is, I think somebody put in there that it was like a curriculum until you get to adolescence. And so I really loved getting to step into that space because I think there's an opportunity to have little things that you do make a really big impact in people's lives. And so I think one of the things that came up over and over again was just acknowledging like everyone has fears and uncertainties with this, from patients and parents to providers. And so I think patients and parents, it was touched on already, there's a brand new system. It may be within the same academic healthcare system. It could be across the country. It could be going into a private practice setting, which is very different from academics in and of itself. The bit of lack of this shared decision-making at times with, I think in pediatrics, there's a lot more, like someone mentioned, conversation, discussion about every single treatment and diagnostic plan. And sometimes in adult care, it can feel a little bit more like paternalistic, where it's just like, here you go. Or it can feel the other end of the spectrum, where it's just like, hey, you're a grown-up, whatever you want to do is fine. And there's not an invitation of adolescents into the decision-making process of their care as much. And so I think it's easy to kind of feel sometimes a little disenfranchised. I think there are also, so having been on both sides, there are a lot of negative beliefs about adult care, and some of them are warranted, but not all of them. I think sometimes there's a lot of fear that people aren't going to be as caring and aren't going to understand the entirety of the journey people have been on. I think sometimes I've had patients come in where they're expecting things to be really, really rough, and they're not necessarily always that way. there's a huge resistance to leave pediatric care. So I always tell patients, I say, listen, you've had a journey with your pediatric provider. They diagnosed you, they got you into remission, and they have walked you through each step of the way. And so I know I don't know you like they do. And I know it's going to take time, but I'm really, really excited to get the opportunity to eventually know you in that way. But I just acknowledged right away that, of course, I'm not the same as they are. And I work in a different system, but just like it took them time to kind of understand your illness and disorders, and to get a treatment plan in place and get to know you as a human too. I think it takes time on the adult side, and so just put that out there to patients right away. Like, of course, that's going to feel that way, and like I'm happy to talk about it. And I love, one of the things I ask patients before they ever come to see me is just, who are you? Like, I play the oboe. I'm like, I've never had somebody play the oboe. That's amazing. I'm a volleyball player. I am working 3 jobs to try to get through school, and also drag this illness along with me and live my life. And so it helps me to just kind of start that way, because it helps to break down some of the, I think, barriers to feeling so distant. There's a lot of shifts in responsibilities that unfortunately happen at the same time as transition. So maybe moving away from home, it may be moving to college, which is very different from high school, maybe starting to work a job. And I think it's unfortunate and just noted that all of those things often happen at the same time. And it's a lot. Just transitioning your healthcare is a lot, and starting to learn some of the skills and knowledge that you need to be able to manage your illness. That's hard. And to do all those things at once can add a lot of additional burdens. And then I think so often, and I'll get to this, I think for me, when I look at just the biggest things that if we would do consistently better would be helpful, it would be starting the process earlier. And there's caveats to that, of course, that if you're diagnosed at 17 or 18, you need a little bit of cushion and time to kind of get things settled. But I think in general, we start these conversations too late, even though it's this inevitable thing that everyone will eventually need to transfer to adult care. We don't give the time and space for it to really be a transition process. And so I think starting, earlier than we do, and it can be as simple as, I think, as was sort of hinted at, just talking, starting to ask questions. Like, as a provider, I love when parents come. And I think any adult provider who doesn't let parents into the room I'll just say is crazy, because I think about, if I have a 30-year-old patient who has, let's say, ulcerative colitis, and there's a decision to change medication, or a decision that they may need to have surgery to remove their colon, what 30-year-old person isn't going to want a parent, a spouse, a significant other, a sibling with them for support? And so to expect somebody who's 18 or 19 to have all these things going on, and then all of a sudden, like, we're going to put you on an island all by yourself, like, that's not even how like older adults operate. And so I think those are some of the things to do with patients and parents. Like, I love having parents there, but I explain to them that for a long time, like, you were responsible for keeping your child safe and okay and on target, and you're making your own transition, and that we need to slowly allow them to do these things on their own, but it's not going to be overnight. And I think the expectation that that's going to be like that is just completely unrealistic. From a provider standpoint, I think there are a lot of communication barriers and issues. I will often, as the adult provider receiving, say, hey, the example was brought up with infusions. Can we share care? Like, let us meet, but like for things like infusions or routine labs, can you keep doing them there where you already have them ordered and you already have insurance approval for a visit or two, just so that we can meet and get to know each other, and wait until, say, after their next infusion for me to put an order in and take over, so that there aren't those gaps in care. I think, as it was said before, I always try to have patients move to adult care and transfer once they're as stable as possible. Whenever there's not the ability to do that, I think that needs to be a physician to physician, a doctor to doctor conversation as to how to make that better. and smoother and as safe as possible. Else was I going to? So anything may come up later, but can you visit with more than one adult care provider before choosing the one you stick with? I love that. I think absolutely. It's so common and it's so underreported that patients will go from pediatric to adult care and they'll schedule a visit, and then if they're able with insurance and if their pediatric provider is willing, they will often bounce back. Or if they get sick, they will bounce back to the pediatric system because they feel safer and understood there. And I think that one of the things that does come up very often are patients who just say, I went and met with that person and I did not have a good experience. And I look at it as like, you know, no doctor is a perfect fit for everyone, but this is your next phase of life. This is such an important thing that I think you absolutely, you know, does everyone need to plan to see 3 or 4 doctors and maybe do speed dating with doctors? That might be hard with people's schedules, but I think if you have an experience where you don't feel like it was a good fit, I absolutely make sure that you find somebody and look around for you know, for another doctor that is a better fit. And I know for inflammatory bowel disease, like we have there's an app that has tried to help a little bit with that, with respect to the doctors who are just more open and comfortable with adolescents and young adults. And Dr. Lawson is sharing, there's a research study looking at private insurance. I don't know if you're welcome to share or can share afterwards, but I think it's a great thing. What I do think is important with all of this is having some endpoint where it's just for clarity, like one that it's transparent so that the, you know, adult provider and pediatric provider are both aware like this is happening. So it's doesn't seem like you're kind of, it's just, I think, better to make sure that things are smooth. And eventually there's going to be an endpoint where, you know, it needs to be fully transferred over. I think, let's see, other things. Okay, thanks for the time warning too. You know, the other thing that I think is interesting, and I don't know all of the, there's probably quite a variety of different disorders represented and covered in the group, but you know, I do think a little bit from a provider standpoint about like risk of what happens if like this is the worst transition ever, and how complex is the disease. And I say that because I take care of a lot of patients who have, you know, irritable bowel syndrome, but there are patients with irritable bowel syndrome where they have incredibly complex histories, and patients with a liver transplant or a solid organ transplant where like if transition goes badly, it's literally life-threatening. Yeah, inflammatory bowel disease, it literally could lead to surgery. And so those I think need a little bit more attention, a little bit more structure. Whereas, you know, somebody who perhaps is seeing a pediatric GI doctor for bad constipation or irritable bowel syndrome, they're, you know, that's milder, they may be able to suffice and do okay with a, you know, a general internist or family medicine doctor, and not need an adult GI. So I think just understanding like the mix of disorders, and that not everybody, not every single condition in every field has to have the same amount of energy and effort, and we don't have to make simple things complex, and we also have to make space for the really complex things to have a little bit more time and energy put into them. I think the one other thing that I just wanted to quickly address is that you know, there are the guidance for this, and I think what Dr. Lawson has done is great. And I know in my own practice, when patients come on board, I always ask to share care for a period of time. I ask for a very specific set of records because I think, you know, when patients come and I don't know anything about them as a human, and I don't know anything about them as their medical system or their medical history, you know, if I was a patient and I showed up and a doctor didn't know any of that stuff, I'd be really uneasy. And so I'll do, because part of my job now is in a private practice that I set up, I'll do discovery calls and I'll kind of hit those salient points, and I'll just ask, what are you most afraid of? What are you most worried about? And what can what can we do, or what kinds of things can we try to build into care that would make you feel safe and heard and seen? And I always send my first note back to the pediatric provider. I don't know all the time if they read it, but I think it gives an opportunity just to let them know, to give feedback, like, you sent this person, the transfer is, for the most part completed, just so that there's some closed loop to that as well. So I think I am near up for time. So
That was also amazing. I really liked you touching on the kind of like the personalized care plans, just addressing each patient as an individual in terms of the severity of their disease, in this conversation of transitioning care, transferring care. Me personally, being diagnosed at 17, that was just the beginning of my IBD journey. I was 18 when I had my partial colectomy, so it just wasn't a good time for me to be transferring care. And then you just addressing starting earlier. It was just a few days ago, I was at a conference and a 15-year-old came up to me with her dad, and he said he never even considered that she would need to transfer care soon. And in specialized care, that's something that's really important. So it's important to start having those conversations earlier. So I really appreciate you touching on that.
sure.
So we will now enter the roundtable talk session of our event. In this section, we will take questions from council members, viewers, followers from our platforms, and hear from Dr. Lawson and Dr. Shapiro, and Ella Chintagunta, a fellow YP area council member. Ella, may you introduce yourself a little bit?
Yeah, hi. I'm Ella. I am currently a college student. I have juvenile onset rheumatoid arthritis. I was diagnosed when I was 13. I would say I've mainly transitioned most of my providers, except for my rheumatologist, because I am very attached and I myself find it very hard to let go of that connection that we've built over several years. But yeah, I would love to start to facilitate some of the questions. So some questions that we've had prior to the call, we'll start a little bit with like the defining transition area. So Dr. Lawson, you spoke about like the difference between transition and transfer, and some people in the chat had talked about some of the changes from moving from pediatric to adult care. I was wondering whether either of you had thoughts about what do you feel like on your side are some of those biggest changes that you've heard from patients prior, and how do you deal with this like almost like bias going into adult care?
I could say, for me, I try really hard to set positive expectations. We actually in our practice try to we'll give our patients a certificate. We try to make it celebratory. Like, this really is another kind of graduation. And I don't want, I understand that, there are certain, first of all, you're very attached to your pediatric providers. There's like extra social work support and stuff that you may not have. So there are some things that I understand people feel like they might be losing, but I think there's also a lot of things people are gaining. And I really try to focus on that in terms of, independence, in terms of being able to be, more a like equal partner with your doctor in decision making. So I think some of that I think there are some really nice things about it too.
I would agree. I mean, for me, I think I already touched on it, but I just acknowledging like you've been on a really long journey, so we're not going to get there in a visit. The first visit is kind of getting your story, getting really critical things tucked in, like medications, surveillance, labs that you need to have done, or and kind of mapping out a plan. I do try to do initial visits close together too, just because there's no way to get through everything. Like, somebody who's had a 10-year course with rheumatoid arthritis, like, there's no way in one visit that I can pretend like, oh, I got you, I figured you out. Like, so I try to just be clear on that. And then similarly, I love asking about their pediatric provider and some of the things that they, memorable moments they have, because I think it gives them an opportunity to memorialize it a little bit. Like it's one of the most important relationships that they've had. So I usually at the top of my note, it's like, school and something unique about them that they want to share, and then a little bit about their pediatric provider, just to start by acknowledging that I'm the new guy in your life and in your journey. So
Yeah, it's really helpful. So I guess another question that we've had in the chat was, what should a patient discuss with a new adult health provider so that the transition is smooth in care?
yeah, I'm happy to go first to this. But I think like the critical things are things to discuss with the adult provider, just an understanding of the journey they've been on with their illness. Like for me, and I'll facilitate that a little bit. I don't expect them to know all of that, but for instance, if somebody has ulcerative colitis, like I want to know when did you start having symptoms? What were those symptoms you were having and you were diagnosed? Complications they may have had, journey through medications to understand like how did you get to the medication you're on now, and their sort of ups and downs that they've had. Hopefully they're in remission, but that's not always the case. And then I think it's always an opportunity to kind of learn. I'll tell them ahead of time, like if you don't know something, it's okay. Like there are records, there's your pediatric provider, but it's a chance for them to, in a disarmed way, like actually tell a story. And I will ask for the data points that I think are really critical for medications and things like that. But I've always had an easier time remembering things in my life if I can kind of think about it in this, like in a chronological story. So I try to encourage them, and if they're struggling, and there's a parent there, I'll let them go for a bit and then invite the parent in. But I'm a big fan of like narrative medicine and the story, and we can always get the data points, but what we often don't get is like, tell me about your experience going through this, and we can plug those in at any time.
So I think kind of to try and piggyback of that for Dr. Lawson, what understandings do you think pediatric providers should like instill in their patients, like prior to that first appointment or prior to that like graduation moment? Are there like specific
Oh, sorry, go ahead.
I was gonna say like specific like lessons or understandings or things that they should like be prepared to share, right? Some of those same things that Dr. Shapiro touched on.
Yeah, that's a great question. I think it's a great opportunity actually to practice telling your illness story, which isn't always easy. It might be even, I can't say I've actually told patients to do this, but as I'm like reflecting on it, I could imagine like sitting down and just like making a little list for yourself of like, this is where I started. Like, these are the big things that I remember. Like when I had that like infusion reaction to Remicade and I like, don't ever want to get an infusion again. Or I like, was on Enbrel and it was like really not working. And then I switched to Humira and it was like, my life totally changed, so as examples of like, what have been those important events along the way. And then I think anything, I think it's helpful to tell providers, certainly if there's like medications that have not agreed with you or like approaches to your care that you found to be really helpful or challenging, could be some good things to share as well.
Yeah, that's very helpful. So one question that we've had several times in the chat is how should a patient discuss transition if it hasn't been brought up? And I think that too from the pediatric to adult world, and also if you're switching from adult provider to adult provider, those scenarios.
I'll bring up just from the pediatric angle. I love it when my patients bring up transition. It's super helpful because a lot of also having the transition conversation, like what's actually challenging for it on the medical end is like the right timing is not always obvious. When there's a ton going on or a patient's sick or you're making big medical decisions, like nobody wants to talk about transition that day. You know, there's like too much else happening. So I love it when my patients bring up transition because that means they're ready to talk about it. They're like, oh, we're thinking about this thing. I'm like, yes, let's talk about this thing. As opposed to, you know, I think sometimes as a provider, when you bring it up and people aren't really ready for it, it can be scary. It can be stressful. They can be like, why are you talking about this? Are you saying you can't be my doctor anymore right now? That's been an interesting thing actually in our practices. We've tried to implement some transition readiness interventions is that we've found we've had to be really clear with patients. Like, this doesn't mean that I'm not going to be your doctor next week. Like, we're talking about like years from now, you know, but people hear that and they're like, oh my God, why are we talking about this? So I think if it's on your mind, don't be afraid to bring it up, you know, and I would say everybody on this call, you know, if you're still with your pediatric provider is hopefully having those conversations. And if you're not, initiate them. It's helpful for everybody.
I agree with those points. I think like two of the things in transition transfer discussions that are the biggest struggle to give, like, here's the best answer are, when do you start? Because for instance, the transition guidelines recommend starting at 12 to 14 years of age. And even if you're diagnosed at that age, most of the literature on when are patients ready from a knowledge and skills and efficacy standpoint, like ready based on whatever survey is being used. The biggest predictor is age in most studies. Communication with healthcare providers and comfort with that is also up there, at least in the IBD literature. But it's a struggle because like we don't want to put too much on people too young at a time when they're not going to succeed, because we want to do, you know, things. So I think just bringing it up and saying, like, hey, I'm 20, as the person who put that in the chat, I think she's saying, you know, I'm 20, I'm really curious or interested in making part of each visit a bit of transition, just so that we don't get to the point at which I have to leave and have everything happen at once. And then I think, you know, one question that's really important, because it differs sometimes even amongst providers within the same clinic, is how long, you know, will you see me for? Because sometimes that's driven by insurance. Sometimes that is driven by providers who won't see patients past 21 while the person next door is being seen, you know, further into their 20s. So I think, as uncomfortable as it can be, taking the initiative to ask for it to be part of each visit, and just knowing openly and transparently, you know, how long can I see you for? Because there are patients who will see their pediatric providers through college. And I think that's the last thing I'll say is, I think there's an opportunity to build play and practice into all of this stuff. Practice calling and setting up an infusion. If you're going away to college, maybe you don't want to transition your subspecialty provider right away, but maybe you get a primary care doctor just for emergencies, and you figure out where the ER is and where you're going to get your labs done and where your 24-hour pharmacy is. And you try to build some playfulness into it and gaming, because I think, you know, it makes some of the tasks a little less daunting than like, here's all your care. Good luck.
Yeah, and I definitely think that like one thing I've noticed is like my doctor is like, oh, you should know who the closest like rheumatologist in your area is in case there's an emergency and you can't reach out to me, and that would be difficult. So I think that totally makes sense. And I think along the lines of that, someone in the chat has said, will it be, it is in relation to going to college or moving out, but will it be, is it easier to be looking for a primary care closer to college, or should I stick with video visits with the primary care? And I can add my own opinion because it is something I thought about a lot, because I moved to States and I really struggled with knowing, like, I want someone close by who can monitor my care. but also, you know, still have someone who I know is in my corner. And I think having someone you know close by, whether they're primary care or they're a specialist or they're just like another specialty provider that you know, is sometimes helpful. But I would love to hear both of your suggestions and feedback on this.
I think it's really personal. I don't think it's a one size fits all situation. So for my patients who are really stable and they're like on a med and it's working for them and they don't have a lot of kind of swirl going on in their care, you know, a lot of times it's easier to keep your medical care where it is if you think you're going to be like going off to college and then you're going to be ready to sort of make the transfer. And I do that with a lot of my patients who have private insurance that can stay, you know, with their parents till I don't keep patients till age 26 because I am not an adult doctor, but I don't have that insurance pressure, right? So a lot of times what I will do is, you know, they'll stay with their pediatric providers. We do video visits as needed, especially if they're not like so far away, like they're still in state, they're going to be coming back regularly. For patients who are very far, so like on the East Coast, or patients who have just a lot going on, then having a local provider becomes more important. Also, if you're getting any kind of infusions, you know, then you often need a local prescriber too, so that becomes a factor in the situation.
Yeah, no, I agree. I agree with all of that. I think I don't know. I tried to find little microcosms. Like sometimes like the big move is a big move, but just breaking it down and you know, if somebody is traveling overseas or even if they're just traveling to across the country for a trip to New York City, I'll just say, you know, why don't you just send me like an email or a text with, you know, if you know what you think emergency medicines would be. It may be in some instances like steroids to have on hand to call in so that they've got that. And like what kind of emergency stuff do you need for like really short term? And it, you know, God forbid you ran into a problem, like where would you go? And I do think there are patients who are really stable where we really just need to know, like if you something bizarre happens, you need to get seen emergently, where are you going to go? Where can you get 24-hour pharmacy, you know, get medications from? And then and a lot of those I'll continue to just follow. There are instances though where somebody's care is really complex, and somebody asked a really great question because it was about like, what if there's diagnostic uncertainty? As much as we like to pretend like we always nail it and it's like, you have this, I have so many patients where they've got a ton of gut symptoms, as I'm sure you do with joint symptoms, and it's not like a concrete diagnosis yet. And they've got multiple different things, you know, Ehlers-Danlos syndrome and mast cell and all these things, and like there's no one home for them. I think in those instances, I mean, those are some situations where I feel like patients often fare a little bit better in academic settings where, you know, providers are a little bit more familiar with like really high complexity care. But I think I often end up getting those patients in my private practice too. And I think when you're making that transition or transfer in that case, coming with all of your records, because they probably come from a lot of different subspecialists and a lot of different tests, and to the best that you can, like what diagnosis have you been given? And it might be 5 for the same symptoms and you're not sure which one is accurate. But it at least gives us a starting point to try to, like, in a situation that just is a little chaotic and uncertain, to have the pieces necessary to kind of reflect on it. And then, you know, getting back to just the narrative, like really think about what was your journey? What was your story? Because it's also an opportunity for a new set of eyes to hear your story and perhaps put some things together a little bit differently. But that's definitely hard because you could probably have like 5 transfers at the same time and pick the one that's either, you know, again, with the risk that maybe puts you at highest risk or the one that impacts your quality of life the most. Start there.
Yeah, so one thing that has come up a few times in all of these talks has been insurance and also the changes in insurance that can be happening at the same time. So a couple of questions go with that. How do you find doctors that fit with your insurance that might also be good fits for the patient? And like, are there resources or tips to help with that, with like changing of insurance?
Yeah, it's tricky and it's not totally obvious. The easier part is if you have a geographic location where you want to be, you can call your insurance and get lists of providers who are covered under your insurance. So that's sort of step one, like who's the pool of people that you can pull from. The next part is a little harder, which is finding that person who's the right fit for you. I think looking to see, you know, some providers have web pages, for example, like I tend to get a lot of young adults because my UCSF web page says that I like teenagers and young adults, which I do. And so more of those folks tend to come to me. But, you know, so you can also look like on their web page and see what's offered, you know, or anything that they kind of say about themselves that might offer you a glimpse into that. I think you have to be a little careful based on, you know, my experience with some of the online Googling stuff. I think you tend to see, I think with any of those sort of online reviews, you tend to see the extremes of people who like bother to post either like really love them or just like had a really bad day there. And it's often like small numbers and pretty random. So I think you got to take that stuff with like a pretty good grain of salt. And then I think talking to other people in your community, like if there are folks through your, you know, local patient advocacy organizations, you know, other young people that you can talk to about their experience, like, oh, I had a rheumatologist, you know, that like someone who lives in your area, like, oh, I go to this person, I really love them, they're fantastic. Like those kinds of recommendations, certainly for like other young folks for sure, can be helpful. And then I guess the last thing I'll say too is if you go, and this was kind of mentioned earlier, but if you go and it's a bad fit, you can go to someone else. So that happens a lot. That you try somebody on, doesn't quite fit, you try someone else and it's better.
There's a question here that's really, I mean, I know we're running low on time, but I think there's a couple other questions about insurance and stress, and I think, you know, with the insurance thing again, it gets back to starting early in the sense that it is different, but most of the time insurance, it does happen where it very abruptly disappears, but a lot of times it just kind of sneaks up on us where it's like, oh no, I'm 20 and I'm going to lose it next year. So I think understanding what the transition of insurance will be and what sort of network of providers there are, it gives you a little bit of a sense as to where you can go and where you can start. And some providers are even open. I don't think people do this often, but you like to just ask, can I stop by and just see the clinic and see what it feels like? And maybe you do or don't get to meet the provider that day, but it never hurts to ask if you can just have like a 5-minute conversation with them. I think it actually shows a lot of initiative. As far as like the differences in treatment philosophies and approaches, the better the sort of transfer summary of sorts, and that may all be in your head or you as the patient, if you don't have a formal summary of what you ended pediatric care with, but the better etched out that is, and you know, being in as best control as possible, leaving pediatric care, I think adult providers are a lot less apt to change things. I think there are some nuanced differences that go both directions. Some of the dosing of medications in adults, for instance, for inflammatory bowel disease, specifically ulcerative colitis, is usually much more aggressive. And so I definitely have had a lot of patients come over on like a quarter of like the normal adult dose, and they're kind of not perfectly in control. And so I think just have open conversations. I understand as a patient when you come to me and the very first visit, I'm like, we got to change stuff. It's delicate, right? Because you're like, wait a second, who do you think you are? And so I think just asking like why, and is that, you know, and having open conversations. And if it's not something that's urgent, like having some time to discuss that. I try not to do that, but there are instances where patients come to me and they're not in remission, or I find something different and I do need to make a change. I think those are always a bit difficult to navigate, just because I completely understand why a patient doesn't trust me yet, and I have to work really, really hard to educate and explain why I really think that this is the best thing. But those are sometimes really difficult. And ideally, pick up the phone and have a conversation with the pediatric provider. I do that all the time with Texas Children's doctors. And sorry, I guess I'm wrong about the time thing. I stand corrected, and I'm glad to hear that.
Yeah, I feel like when, and Jordan, you probably, I imagine probably in your experience too, like if you have a little time to kind of get to know somebody before you're like, okay, let's go change everything, like that is definitely, I think, easier on the patient. So that is a thing I try to sort of encourage my adult colleagues to not dive like right in and recommend a whole bunch of changes, like unless there's obviously, if there's a medically pressing reason to do so, by all means. But to kind of take a little more of a shared decision-making approach, like, well, are you happy with your control of your symptoms? Are you not happy? If not, what do we want to do about it? These are some things I think could be reasonable. Tell me what you think. And so that might be a way to approach it.
Absolutely. No, I appreciate that insight. I think there's always some things that like I don't understand about pediatric care that I learn about. And then one example that's always really tough, and I don't bring up the first visit, is just for healthcare maintenance in adult like inflammatory bowel disease, is colon cancer screening and an increased risk. And it's that, and some of the vaccine schedules for patients who come to adult care at 18 often have not been even broached at all. And for patients who've had ulcerative colitis for more than 10 years, like there are recommendations to start doing earlier colon cancer screening and a lot more frequently. And so sometimes that's just one of those things where when I'm mapping things out, I'll leave it as broad the first time, like this is something you may not have talked about. We're going to talk about like how colon cancer screening looks different. I won't get into like you need to do that. We're going to do this, because it definitely can be overwhelming. And I also do find that I think if patients are kind of transferred and they're not in remission or in control, there's definitely more openness to like, hey, this is not optimal. Like I'm open, as opposed to somebody coming over in remission and being told we're going to completely change the infusion, the biologic medication you're on without clear reason. So it's definitely it's a dance. And one other thing I would throw in there is I try to sometimes I'll draw out I think in pediatric care, so much of it is focused towards the parent. And I really try to say, I will tell parents, I never tell them go away. I will do what, another thing that's in the guidelines, kind of like I talked about, and we recommend starting transition conversations at 12 to 14, and that never happens. The pediatric Bright Futures, which kind of gives us all the anticipatory guidance recommendations, they do recommend it at 14 years of age, that even with your general pediatrician, that you should have time alone with them during visits. And that's very rarely done. So as an adult provider, what I'll do is I'll always have the parent come in and I'll ask, what's your experience been with time alone with the provider? And I'll let them know for all my patients who are over the age of 14, because I do see patients down to 14, 15. I do have a portion of the visit where I have a parent step out. I'm so glad that you're here. You have helped get them to this place. And I absolutely am. I do not want to kick you out of the care team. You're a very important member of the care team, but we need to start again practicing what this looks like. And so if your providers aren't doing it, I think it's another way to just create 5 minutes of practice. Even if you don't have specific things you want to talk about with parents, I think it's really important to learn how to communicate with healthcare providers and be comfortable with that. So just another thing that came to mind to share.
Yeah, that's all extremely useful. So maybe some questions from the chat. Do you have any tips for reducing or managing the stressful components of a transition and hopefully avoiding a flare?
Yeah, so this definitely, you know, we know that the immune system is definitely affected by stress, and for sure, my patients flare when they get stressed. That's definitely a real thing. I really try to do some coaching with my patients, especially folks who are going off to college. They're going to be living in dorms, to talk with them and sort of try to imagine how they're going to take care of themselves when they're in that environment, and like think through some of the specifics, like what's your medication routine going to be? What time are you going to go to sleep? What's your eating going to be like? Like to be intentional about that stuff. And not that everybody's going to be perfect every single day, but really reminding people that even when you're in this kind of like exciting and chaotic environment, because of what you're navigating, you need to get enough sleep most nights. You need to eat healthy food. You know, you need to exercise. You need to take care of your mental health. And making sure that, you know, those things don't fall off, and that you need to take your medicine. I will, you know, for patients, you know, that I am particularly worried about, I'll do a video visit pretty early on after they get to college, just be like, how are you settling in? How are things going? You know, but I really try to like talk about, like, not just like, oh, make sure to do this stuff, but really kind of try to talk about like, how is it going to work for you? What's the routine you're going to use?
Yeah, I think understanding what the current skill sets or like stress management things are, understanding and it depends a lot on the condition. There are definitely conditions where stress can induce a flare of inflammation. There are also a lot of things in GI land where with the gut-brain axis, there may be symptoms. It may not necessarily be that it's worsening inflammation, but still just acknowledging like you may not feel great. And when that's there, how do you stop kind of just pushing ahead and create some space to take care of yourself? And I think, you know, I guess I can speak more specifically to GI, but what are the points at which we worry that this is just some stress induced pain, bloating, or diarrhea? Versus is this the beginnings of a more significant flare? And so I'll often talk through like what is like the first thing you're gonna do when you start noticing this. And I hope that I'm not like maybe I'm not the first thing, but I hope I'm like in the top 3 that they'd let me know, and I'll let them know that. And then we'll kind of talk through like if it's persistent beyond this much time, we may want to consider just doing like some really basic lab work to make sure that, you know, we don't need to think about using a brief course of anti-inflammatory medicines. But yeah, I definitely think that planning it out and just walking through like what would you do if this happened, like, and do some contingency planning. And I always try to disarm people and make them we're not worried that like this quiz is failable. It's just like I'll say, you know, I want to just ask you a few questions, and I want to see like the ones you know the answers to, great, and the ones you don't, like, you'll know by the end of this conversation, so don't worry about it. And it gives people an opportunity to just kind of think through some scenarios that it's a lot better to think through when they're feeling good and they're talking to you in the office than it is when they're away at college and it's like 10 at night and things are kind of spiraling.
Yeah, I think those are all really important points. This next question I find to be extremely interesting. But the question is, how do you handle cases where there might be differences in treatment approaches or philosophies between the patient, the former or transferring provider when it comes to continuing care? And maybe this also goes with like the idea of maybe like trialing adult providers but
Yeah, I think it's tricky because I think it's about finding that right fit, right? Like you know, hopefully have good alignment with your pediatric providers that you've been working with for a long time. And then I think also, you know, just saying to the adult providers, as you're meeting them, like not being afraid to say like, this is what works for me, like this is how, you know, this is the approach to care that you know, or my sort of philosophy around my care, and sharing as much information with them around that as possible. I really try to do a lot of talking with people about how they feel about medicine. Do they hate it? Are they fine with it? Do you, you know, and then trying to balance that, you know, questions about how controlled their disease is and how they feel about medicine, and how do we sort of get those into the best possible alignment in terms of optimizing symptom control and being on a, you know, amount of medication that they feel good about. And, you know, and I think being able to kind of try to vocalize some of your feelings about that to your provider may be helpful as you're getting to know each other.
Yeah, I think I know I touched on it briefly before, but I agree. I mean, I think there are a lot of places in medicine where there are multiple right paths to something. My general philosophy is if it's working, like don't change it, even if it's a little off the course of what I might do or the most recent guideline. Like if somebody's doing really well, transition is not the time to change and transfer to change things just to cosmetically make them look nice, because it's it's just asking for more trouble. And so unless I think somebody, you know, it's something really, really, really straightforward. And I'll tell, you know, a really common example is like with ulcerative colitis is like the pediatric dosing of like one of the common pill forms of treatment is weight-based, and like so many medications in pediatrics. And in adult care, it's just like if you're 18 and over and you have this, like you just take the maximum dose. Like the side effects are all, none of them are really dose dependent. And so I'll often get patients who are on like half the dose that I would use. And if they're, I'll just say like, and I'll have a conversation. It's like, oh, this is, you know, that lots of things change when you turn 18. And one of them is like the way that we dose this is that we usually just go up a little bit, and I'll recommend that we're just tweaking it up. And it's not about like right or wrong. It's just it's different. Like and I think it goes back to a little bit just understanding too, though, people's experience in pediatric care. And having, you know, I'll have conversations with them about what are the things you like about pediatric care? What are the things that you maybe liked at the beginning that got a little hard at the end with, and maybe with respect to like how front and center a parent is. Somebody used the term helicopter parent before, which I got yelled at in a paper I submitted for using, probably rightfully so. But yeah, just having a conversation about the things they like and don't like, and trying to meet in the middle as much as you can. There are certain things in adult care that are a struggle. If you miss an appointment, you're late to an appointment, there tends to be a little bit, it can feel a little bit less forgiving in some settings. It's like, well, you're a grown up, you should have known better. And I think I try not to do that, but I acknowledge that sometimes adult care is a little bit rougher in some settings in those ways. But I also think that when you walk in, it doesn't mean you have to nail it, because I will tell you, my 40-year-old patients, if I ask them, and this gets to the transition readiness thing too, age matters a lot, but at the same time, if I ask my 40 and 50-year-old patients really detailed questions about their medicines, spoiler alert, they don't do a great job all the time. And so I think sometimes we hold adolescents and young adults to these expectations on both sides of the street that are like unrealistic for the average like older adult. And that's probably one of the things in transition research and literature that I think maybe hasn't been as helpful and fair to patients, is that we will define like what is mastery, like 90% of the questions, 5 out of 5. And I'm like, I can't find adult patients that can do that. So why is an 18-year-old supposed to do that? So yeah.
I've heard that from adult doctors before. Our expectations can be unrealistic.
Yeah, I definitely think that is extremely true. So another question we had from the chat was, how do you recommend navigating the adult transition when you don't have a clear diagnosis, but you know your illness is clearly pediatric onset? We might have touched on this a little bit earlier, but.
I think I would just say work with your trusted providers to figure out what is the right care for you on the adult side and have them help you in terms of providing medical records. So like those providers get access to the information that they need to help assume your care. Yeah, but I would ask I would go to your pediatric providers to say like, where is the right place for me? And have them help, lean on them to have them help you answer that question. Adult PCPs can also be good for that too.
I agree. I don't know if I have a lot to add. So.
Yeah, so I actually have a question for each of you specifically. So I guess first for Dr. Lawson, this has been in the chat a little bit, but how often and in what ways do you feel like patients should contact you versus contacting the adult provider during this process?
I often have a period of overlap. So for example, I just saw a patient for the last time last week who I've been following for many years. And I talked to him. He's like, okay, I want to go to this rheumatology practice near where I live. I'm like, did you check with your insurance? He's like, yeah, it's good. I'm like, okay, why don't you call them next week? Set up an appointment. So he got his appointment. He saw the doctor. I saw him again. I was like, how did it go? He was like, it was fine. So I'm like, are we ready? Can we be, do you need me more? And he's like, no, I think I'm okay. And then I said, call me if you need me, and he will continue care with the adult provider. So I think just having, it doesn't have to be this abrupt cutoff. I always tell them my door is open if you need me. And so, I think having that period of overlap can be kind of normal and natural as you are getting established.
I would agree. I like that. I think, does everybody need back and forth, or I don't know. I used to refer to it as kind of ping pong care, but I think when it's delivered, it's more than ping pong. But I think it depends a lot, and the number of times back and forth depends a lot. But regardless of how much it happens, I think one of the areas of potential threat, and there's an opportunity to do a better job with this, is just closing the loop. When are we going to stop doing this? Because I published a small paper on transition with the pediatric liver transplant patients, and those are patients where we know if things don't go well, they lose their liver, and I mean it's life-threatening. And there's a higher mortality and death in those patients during the transition period. And so one of the things that was a little scary to look at retrospectively, because it was like long after this happened in this data set, was just that, from the time a patient was sent to adult care, how long did it take them to get their first visit? For some patients, 3 months, 6 months is okay. For some higher risk patients, it's not. It needs to be, a few weeks, maybe, or a month the most. And then the second question was, what happened after the first visit? Some patients didn't see either side for a very long time. Some bounced back to pediatric care, to clinic. Some ended up in the ER, in the pediatric side, and some did see the adult providers again, but there was like a 12-month gap between visits. So I think just planning deliberately a bit better, and it might be that it's one shared visit. It might be that the first visit goes great, and they're like, "Hey, I'm cool being on the adult side," and then I send my letter to the pediatric provider and say, "Hey, we've completed the transfer." And I think, unfortunately, sometimes the folks who get the least say in that are the patients. And so I do ask patients, is there anything that feels unresolved where you think like doing a visit, you know, back with your pediatric care would be helpful? And making that okay. It's not a threat to me. It's not because you don't like me. It's, you know, it's not about me. It's about them. So I think just doing it in that way, people feel like less of a pawn, and they feel like, oh, people actually care about the fact that all of this is supposed to be about me being able to kind of like find and advocate for myself and find my new team. And I'm getting treated like that. So that's all I would say.
I would echo that. I do think it's important to know who your doctor is. So sometimes we have this period where like one person's coming in, one person's coming out. Like this actually applies for second opinions too. Like I always tell people, I'm like, you can't have two doctors because then your quality of care is going to suffer because nobody knows who's in charge. So there has to always be someone who's in charge, even as you're like maybe getting to know the adult provider. And I try to be really explicit, like I was talking about with, you know, my patient that I saw last week, to say, okay, are you ready for like the adult doctor to have the wheel now? And he's like, yeah. And I'm like, okay, we're done. Yeah.
Yeah.
So I think it's good to be clear, like in your mind, and for your doctors to be clear that like who's the person in charge at this point in time.
Yeah. I think sometimes I like to also think about like, what is the bare minimum you need to make this work? And I think if you have a really clear target who's open to communicating with the pediatric provider and insurance, I mean, you can have like the 6 core steps of transition and core elements of transition, but like they're messy and they have the difficulties in interpretation and lack of clarity on how to actually like make those into actionable things all the time. But I also think sometimes we, you know, to play the devil's advocate, I think there are ways that we probably make some of this more complicated, especially in some patients, than necessary. And I think take the simple and let it stay simple, because complexity, the hard things are going to show up. So I often think about like the things that I can do almost nothing about are on the adult side. If the insurance thing hasn't been set, it's going to be hard for anyone to fix that. So I think you have to have a way to access care, and then picking a target that knows they're the target and has some sort of handoff, even if it's just making sure you carry the records to them. Nobody climbs a perfectly smooth mountain when it comes to transition, but we can try to make sure it's not really jagged rocks. I think that's been one of my takeaways, is sometimes I would love to have a conversation, but if I get all the records, like, you know, I'll sort it out. We'll eventually sort it out, but we're trying to avoid like gaps in like the really critical things, which often come if all of a sudden somebody's unable to get the medication, or they're not explicitly handed off to an adult provider and they're flaring it. And those are the times where I see patients end up, their first visit in adult care is in an adult emergency room, which is really traumatic, and ends up taking a lot more time to get people kind of trusting and into a stable place. There's a question about adult care real quickly. How do you handle when your doctor and all the doctors in the state don't understand the situation? Also don't have the time to understand. Have a lot of adult clinics that don't have nurses. I notice I don't see nurses anymore. I think the models of care are different. I mean, in general, you walk into a pediatric clinic and everyone is really smiley and happy and you're welcome. Then there's like layers of like the welcome brigade, and you see the same faces most of the time. I miss that about practicing in pediatric care at Cincinnati Children's and at Texas Children's, but I think there are things in every field where I think the more that might be a time when you, before transferring, that you tried to, in the pediatric care model, say, I know this isn't super clear cut, but to the best that we can we try to make, like, where there are concrete or more likely diagnoses, list those, because I do think, like, I see a ton of patients who come and they've had 5 doctors and they never get a diagnosis. And I will often tell patients, all of your symptoms fit this and this and this. That doesn't mean that things can't change. It doesn't give me permission to stop thinking, like, because there may be more to it. But the more patients I think are, I mean, even if it's not during a transition, are left with really vague, I don't know what I have. I think you can usually commit to something. And we need to do that as providers to be able to even start to try to treat something and move in a direction. So I'd rather be committed to something and try to pin those things down and be wrong and just circle back or be partially right, but to stay in the sort of abyss of symptoms. And so I would just say go back, you know, and try to ask that. And then the last thing I'll say is there are cases where I think academic centers do a little bit better job managing those, but there are things like the undiagnosed network that I used to do consulting for, where a patient or a provider can submit a case that we just can't figure out to try to get some clarity. And so, yeah, those are very difficult things for sure, though.
All right, so that was amazing. You guys touched on just so many points that are helpful to me. And I enjoyed this so much, not only as a YP area council member, but also as a patient that is currently transitioning. So I just soaked up so much information. So thank you guys for being here. Thank you to everyone who logged on to attend tonight's event. Once again, thank you to our speakers, Dr. Lawson and Dr. Shapiro, and our fellow council member, Ella. And an especially big thank you to our community partner, Infusion Access Foundation, for their partnership. Make sure you check out our council website, where we have so many amazing informative blog posts linked and more about our members. And then also our Instagram at YP_area. Also, please consider giving us your feedback of this transition table talk through a link that will be dropped in our chat. And once again, thank you so much for your attendance, and we really hope to see you soon.
Thanks so much for having me. It's such a pleasure to get to spend some time with you all.
Likewise.
Thank you so much for coming.